if you wouldn't mind telling us a little bit about your program, and how you guys created the collaboration between you and Dr. Itkins.
Sure, thank you. Hi, everyone. So we started in 2018 when Dr. Itkin and I decided to do any pediatric cases here. And I think the best thing that we did was initially reach out to all the subspecialties and get them involved in the program from the beginning. So cardiology, pulmonology, GI, cardiac anesthesia, general anesthesia. We pulled in reps from the PICU, nutrition, social work. And so we had a fully functioning team of people who really were interested and made themselves knowledgeable about the malformations. And so now what we do is, we get a referral and we have a big meeting with all the relevant subspecialties to make a plan. And I think that has been the best part about our program, is just the interdisciplinary collaboration. And I think that's what's made us beginning to have some success. It's just, we have everyone we need, especially also including the surgeons and the plastic surgeons.
Yeah, I think one of the things that's going to be brought out in this case is, in particular, this is a collaboration where you guys were able to help us with a patient from our center, and so it'll demonstrate kind of the multi-center collaboration between that. Dr. Itkins, I don't know if you have anything to add as far as how you've built up the imaging program over the last few years, at your center.
Thanks, Teresa. So the most important thing, of course, motivation, enthusiasm, right? So if you don't have somebody to collaborate and work together, it's impossible to build anything. So somebody has to be as excited about the opportunity as I always been. And Debbie is, of course, a champion. He goes through all length just to make things done and complete it, because it's complex to set up a lymphangiogram program. It's not easy to set up, to bring everybody to the table from specialties. It's not easy. And of course, we have the fortunate to have enormous support of administration that ready to dedicate the resources, people, and money, and just making sure that program is successful. Without that, there's absolutely no chance somebody can be successful. You need to have support of your institution, strong support, and we have one. So pretty much we have every week meetings, both business and planning and clinical and everything else. And we have administrators that are running the program. They hired people, they bought equipment for us, and so on. So that's another thing. And again, back enthusiasm. So somebody has to believe it's going to be successful.
I wanted to just check in and see, Dr. Cato, do we have audio for you yet? I apologize if that we've been having such difficulty, no matter what, thank you for being here, because it has to be a difficult hour for you in Japan.
Oh, thank you. Can you hear me now?
Yes, we can. Yes, we can.
Great.
Yes, it happened. Multiple countries united.
Yeah. Thank you very much for giving a chance to attend here. So I'm now exciting. Okay, thank you.
Yeah.
Connection of the audience too.
Dr. Cato, do you mind giving us, just a little glimpse of what is the program like that you've built? What are the resources and collaborations you have, locally at your center?
Actually, it's a very good question, and it's a very difficult program. I usually work with the pediatric physicians, but sometimes I collaborate with radiologists. But the problem is the radiologists, the number and the techniques are not as many as in United States. So we are now trying to connect and more functional opportunities for the patients. That's the story now.
Yeah, no, I mean, I'm excited to have you here. I think that Max and Debbie would agree. Whenever you speak at an ISPA meeting, you capture the audience. People love your presentations. I've always been a fan. I remember you presenting in Amsterdam and even the virtual one recently. And I think you've allowed to have some really good exposure for the field of the microvascular surgery, and so we're really thrilled to have you with an audience that I can see is from all the way from Algeria to Kentucky, as far as it looks like that's joining us today. So without further ado, I think we can jump into the case. Let me get into it. All right, so I'm going to go ahead and introduce the case because it started here in Colorado. It'll end up with Dr. Rabinowitz shortly, but once upon a time, a baby girl presents with a prenatal diagnosis of macrocystic lymphatic malformation of the left chest and axilla. So there are prenatal MRI imaging that demonstrates the lesion. That allowed us to, know that this would be a cesarean section birth. It was an uncomplicated birth, and we have some evidence here that you can see kind of externally and internally how the lesion looked. I think the next film is the MRI. I apologize. I've neglected to introduce who's sitting right next to me, Dr. Aparna Anam, our director of interventional radiology for the Vascular Anomaly Center here. And maybe you can comment just a few
Sure.
comments on the initial lesion.
Right, so these images are actual coronal and axial images of the baby, which we can actually see these really hyper intense fluid-filled cystic lesions here along the chest wall and along the axillary region. And what we actually can say about this is that this is very big. The baby can't place their arm down by their side. And so this actually warranted treatment early on during infancy, so we could actually try to reduce the size of this and increase the mobility for the baby. In one of our previous images, we actually did show that we just treated it with doxycycline. That's our last image all the way over there. And we had a pretty decent response. So we'll see some of those images now. And so, as you can see, we started with this large mass where the baby couldn't put their arm down, and then now was able to actually bring the arm down. And there is actually some redundant tissue, some soft tissue that's there, but otherwise was doing very well.
So I don't want to spend too much time on this one because I've got so many meaty questions to ask you, but maybe I'll start with Dr. Rabinowitz with this one. In a perinatal consultation or the postnatal presentation of a macrocystic lesion or a lymphatic lesion, what goes through your head in the decision making of how early to treat? What are you trying to prevent? What do you base a decision on how early to go after a lesion?
So basically, when I look at a newborn or a fetal MR, the main thing I'm looking at, just like Aparna said, is the baby's function, is their development impacted by this? If they are in any way, so if it's pressing on anything that I think is dangerous, of course, like an airway, but even if it's pressing on a kidney and the kidney is smaller than the other kidney or something like that, or if the baby can't put their arm down, I would go ahead and treat as early as possible. If it's not really causing any kind of functional or developmental problem, then I usually try to wait for 6 months just to decrease the risk of anesthesia, and let the baby be a little more robust before I treat. But in this case, I certainly would have treated that just for the arm to have the full range of motion. And of course, if the baby ever gets an infection, I go ahead and treat then.
So, to be continued, by roughly 2 years of age, she started to, report that the malformation had a little more symptomatology, a bluish hue, had a little more concern of a venous component. You could kind of palpate the phleboliths kind of underneath the skin. We really were trying to encourage the family at this time for follow-up imaging. It wasn't necessarily pursued just, as far as, shared decision-making with the family. But certainly there were some red flags as far as that the lesion was becoming much more symptomatic. To the kicker, which is when she presents acutely with increased work of breathing and shortness of breath, very easily on exam, let alone imaging with plain film or CT or MRI, that there was a large pleural effusion in the left side. And maybe I could have Aparna just take me through real quick what goes through the mind, under the eye of, radiology, when a kid presents like this, what's the 1, 2, 3 that needs to go through your mind?
Well, knowing that she presented acutely, we obviously have this imaging that shows that not only you're seeing the soft tissue density here, which is her lymphatic malformation that's probably increased in size, but you can also see that there's some mediastinal shift over to the right, and that just indicates that this is a large volume effusion that's actually been building up and actually displacing our mediastinum. And you can see this better on these coronal images on the CT. This is this huge effusion here. And so we have to, keep that in mind and look at what are the causes of that. And so given that that's really in the vicinity of her lymphatic malformation, that a chylous effusion is certainly in the mix of what it could be. Could it be just simple lymphatic fluid? Could it just be a perineumotic effusion? It could be any of those things. But once we actually get some fluid, we'll really know what it is.
So maybe, a question that I would throw out there, at this time point is, this is quite the, evolution of a lesion, and, you can almost see at the bottom of this image, the splenic involvement, the organomegaly and the splenic involvement here, to say, that what was once thought to be a very localized lymphatic or venolymphatic formation has shown something more dynamic, in nature over time. I don't know, maybe we'll start, Dr. Itkins. What do you think about, the ability of this lesion to change over time? What are your expectations? You've just finished in infancy sclerotherapy for functional improvement, yet this had such a dynamic change. As far as your expectations and your experience with the field, did this sneak up on us?
That's very, 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 very good questions that we started only recently to dig in. So we truly don't know what lesions become progressive or what lesions are not progressive, right? So what's the cause of this progression? One of the potential preventable causes of this progression is leakage of the thoracic duct, right? Imagine yourself, you have what we found in this patient, big connection between the thoracic duct and this malformation. So slowly, because of mechanical pressure maybe, this lesion continued to grow and grow and grow. And that's the reason that right now when Debbie present with some lymphatic malformation case, sorry, I have my dog on background because I'm at home. So present with neonatal lymphatic malformation of this size, we will immediately do MR lymphangiography. And we will offer the family and the referring physician, I'm so sorry. Sorry. Unfortunately, I can't do anything about that. Because, all right. So we'll discuss with them this option. Of course, we do disconnecting thoracic duct and reconnecting thoracic duct back to the venous circulation. And we have patient very similar, right, Debbie, who we definitely had discussion. The patient is completely asymptomatic. We did not yet do anything about that, but she's by all means on our radars in a sense to potentially in the near future to connect this thoracic duct to the some type of vein and disconnect from this malformation. David, would you agree?
Yeah, it was because of this patient. I recently had a new patient who had a large left chest wall malformation that actually went into the left retroperitoneum as well. And so it just sort of reminded me exactly of this patient. So I did a cone beam lymphangiogram on the table when I was doing sclerotherapy for him. And his thoracic duct was partially obstructed, not completely. So it was just narrowed. And we'll see how he evolves. We took a biopsy. We're waiting for the genetics on it. But I think that might give us a clue as, if we start doing these very non-invasive lymphangiograms while we're already doing sclerotherapy on these patients, it might give us a clue on the actual evolution of the process. You know, he doesn't have splenic involvement right now. He doesn't have bone involvement right now. And so I think, you know, like, we're still learning it, but yeah, I was surprised. I thought his thoracic duct would be normal, and it wasn't, and I was surprised. So I'm wondering if she had a similar initial course, but no one would think to have done it initially.
And that's a very good point. Just
no,
for
go
a
ahead.
second. Very good point of David. So recently we started to do for neonates cone beam CT lymphangiography. That's extraordinarily simple to do and provide you excellent visualization of the thoracic duct. Because in one spin you can cover the whole body and get beautiful images. I know that Debbie is finishing the manuscript about that, but it's very good option, very simple one to evaluate the central lymphatic system in patients with this type of condition. And I think we need to do more of those because we would like to understand how much this malformation communicate with a high flow system like a thoracic duct. Sorry.
No, I was going to say, oh, sorry.
No, I was going to get Dr. Cato's take. You know, if you know that you get a call from the pediatric side of the hospital, and you know this is the kid that they're describing to you. You know, what are the first few things that go through your head in an evaluation to categorize this patient for you?
Scintigraphy, I think, because MRL lymphography is very feasible, I think, to perform. But in my institute, we have no ability to do the MRL in 100%. So I would do scintigraphy first.
Yeah, I think that's very fair. Dr. Rabinowitz, I didn't mean to cut you off if you had something to add.
Oh, no, I was just going to say that I have, if at some point we have time at the end, I can show you the CT lymphangiogram on this patient that we actually did one on her as well. We did one on the new baby, but we did one on her as well. And so I could just show you the images later.
I wanted to address, because I conveniently have a slide, there's a message in the chat from Dr. Teplitsky that says, is there a method to define the fluid as lymphatic? You know, is there a lab or specific findings? And by all means, this is not definitive, but, you know, some guidelines that we use at our institution, you know, obviously we ask the interventionalist or the surgeon about the appearance of the fluid that's coming out of the chest tube or in a procedure. We look at the serum protein ratio, you know, and we look at the fluid LDH level, the presence of chylomicrons or fat, the glucose level, and I think the kicker for most people is the triglyceride level. You know, so I have it listed here: elevated fluid triglycerides greater than 110 milligrams per deciliter. You know, I think that is often one of the first things people try to screen. It's probably the easiest thing on the fluid you could get back, you know, in a short period of time. You know, again, my hematologist mind always starts to look at both the lymphocyte concentration in the chylous effusion, but also the lymphopenia that's starting to occur in the peripheral blood, you know, as it starts to leak, you know. And so I don't know if there are any other key tidbits from any of the guest speakers today on how you prioritize identifying the fluid as lymphatic, because that is probably the first question you have to ask any consult that's asking you is, are you sure it's lymphatic?
So I'm doing it for 20 years and I'm still don't know what is lymphatic fluid. So, and the first thing we always check, the first question we ask, we're trying to characterize the fluid when we get a new referral. Triglycerides 110 number is very misleading. It comes from the paper from 76, I believe, from Mayo Clinic, where they pull all pleural effusion, send for chylomicrons, and then they, whatever have chylomicrons positive, they said, oh, this is chylous, but by definition, and then they plot the old triglycerides level. And number one, the problem with the study was that 30% of the fluid were bloody, right? And we know that chylomicrons live in blood and in the chyle. right? So it's already was tinted, number one. Number two, we clearly understand that the level of the triglycerides depends on the feeding. And every time you get the number, you have to ask a patient what's the feeding status. Of course, you got 400 triglycerides level, you know it's chylous for sure. But when you come close to 200, you have to be very, very careful. And in reality, if you're in doubt, just feed the patient. Give them cream and see how triglycerides level changes. The rest of the stuff, lymphocytes probably 50, well, I would say 60%, but you have to be very, very, very careful. Why? Because if patient has a little bit infections, neutrophil count will go up. So watch for that, right? So and immediately the lymphocytes count go down. Also, you have to see how many cells are there, because I can get a 50%, 80% lymphocytes count, but number of cells, if you look total number counted, will be 10, right? Probably it's not right. So you have to, these two things you have to always keep in mind. Look at the cells count, the how much neutrophils, because infection quite common, and total number of cells. You can do statistics out of 10 cells. It have to be hundreds of thousands. And the last thing, albumin level is very important because, but also very confusing. Most of the soft tissue lymph has a low level of albumin, but liver and intestine has relatively high. So I don't know exactly what's the number. We always check albumin, but I'm not sure what's exactly number has to be with albumin.
So, just keeping an eye on the clock, I'm going to want to jump into the meat of what you guys do in just a short minute. But I wanted to take 1 second with Dr. Anam next to me to kind of get a sense of what this is the question I'm going to have. What does this patient have? What are we calling it? What are we actually treating? So right. What do you see when you look at this kid?
We actually did do an MRI chest, abdomen, pelvis, and just to be very inclusive of everything, we actually did also scan the extremities with a total body MRI. And what you can actually see here is that we have our patient now, again, this lymphatic malformation that was there in the chest wall and axillary region has returned. It's much larger in size. We actually do see a mediastinal component now that is more prominent than we did not really see on her previous exams. We also see her effusion here as well. I believe this was done after she had a chest tube placed. And then when we start looking at the rest of her body, we also see that that wasn't just a variance in perfusion in the spleen. These are actually cysts that have developed within the spleen. So she has all these kinds of cystic lesions throughout there. If that's lymphangiomatous, most likely. And then we also see these other fluid-filled cystic structures throughout the osseous structures. Now, there's no real osteolysis that we can appreciate. We don't see destruction of the bone, but we do see a lot of these lesions, and we also see them here along the distal femur and the distal tibia as well. So this actually just points us to a much larger systemic process that's going on.
So as I, ask the question, and it doesn't have to be, so in-depth of an answer, and we don't necessarily have to go through this slide ridiculously in detail, but I just wanted to throw it up for academic purposes. We were basically calling the patient a generalized lymphatic anomaly, the ability to see systemic involvement, bony involvement, kind of almost skip lesion bony involvement, and not destructive Gorham, progressively destructive bone loss, but yet bone involvement. We were working under the working diagnosis of general lymphatic anomaly. Briefly through the three of you, what would you be writing in your report as far as the diagnosis here? Maybe starting with Dr. Rabinowitz, yeah.
Yeah, if I was writing the report, I would call it a generalized lymphatic anomaly versus a composite-form lymphangiomatous, just because if I was just reading the MRI, because it's difficult to tell the findings. I agree the lack of cortical involvement would make me shy away from Gorham-Stout disease. Central lymphatic fluid disorder or central conducting lymphatic anomaly, I would expect to see maybe more ascites, more anasarca diffusely. So I would definitely have thought this was a systemic complex lymphatic malformation like GLA or KLA.
Dr. Cato, if you had to sign this patient out to someone, what kind of category of classification would you be using here?
Well, it's that's a good question, because very dilate, diagnosis is a little bit difficult in such cases. I would say GLA for the first choice, but I usually call in my institute it's an lymphatic disorder, but not detailedly not detected with just this survey. So either lymphatic scintigraphy or lymphatic MR lymphography would describe how the central system was going on. So probably these things, these problems can have some relation to the central lymphatic system obstruction or congestions. So partially it could be a CCLA also.
I think that's very fair, and you start to get into the next question that's going to come up, which is, how are we going to image this? I want to give an update on the patient at this time. This is something we're categorizing as a high flow lesion. So remember, this is a little 2-year-old, and she's putting out close to 3 to 4 liters a day. So well within a high volume leak. She has multiple chest tubes in place where we're actively replacing fluid and electrolytes, because that's a lot of high volume loss, that's occurring. As Max alluded to, there's albumin, hypoalbuminemia. We're replacing it with a goal to try to keep it above around 2 or 2.5. And that's sometimes you feel like you're in a vicious cycle, that you're just doing it to keep putting it in, but it helps kind of keep the protein up and keep the third spacing down of edema. Although there's some conversations we could have about modifying diets in the low flow cases, this was a complete NPO, go straight to TPN, don't pass go, not to feed the child. We had an adjuvant therapy with octreotide, and then inevitably we ended up adding sirolimus, which is a discussion to itself, under the perchance that the pathophysiology has something to do with the PIK3CA pathway, mTOR, the AKT PIK3CA mTOR pathway. IVIG, there was some replacement. I think we can all agree that this is another product that we feel sometimes we're chasing the number, and it's only putting it in to come out the other end. But we were able to keep a physiologic normal for this patient because she was having some fevers, and I think that's the illness or fever sometimes gives you the motivation with IVIG to keep it up, and without it, you just kind of feel like sometimes you're giving it. Good pain control, line access, NG placement, and she had some BiPAP support, because you can imagine she was breathing against not only the pressure against her chest, but a pretty decent belly, as well. All right, so she's sick, and I'll just throw this up for 1 second. And potentially, if people are interested in this algorithm that we use locally, we can use it. You can look up the publication down below to look at it. But really, it just triages based on the symptomatology and the flow, high flow versus low flow of a lesion, in the triage. So I'm going to come back to that in a second. What are our imaging options here? You guys have alluded to this, and inevitably it's tied to the next question, was what is our interventional options? And maybe this is a good time point to kind of go through the roundtable. I don't know if I want to give Dr. Anam first chance, because she had the first chance.
She did have the first chance. Yeah. So I actually just wanted to show just an example of what we don't necessarily do a lot of lymphoscintigraphy on these patients. But I did want to show there's the comparison between what lymphoscintigraphy is, MR lymphangiogram, and a conventional Untitled lymphangiogram. And this is actually lymphoscintigraphy, where you can actually see we inject radiotracer, an intradermal injection in the feet. We then follow this up. It's actually in the interdigital web spaces, and we follow that tracer up through the body. This actually here at these delayed images, we're actually seeing inguinal node uptake, and then we're seeing, this is her xiphoid over here. We don't really see much in between. So when we actually have a picture like that, I can say that the lymphoscintigraphy is telling us how the lymph is moving through the body, but we're not seeing it with its native structure. So we're not really seeing what's the anatomy around this. And, so that's where I think it does give us some useful information, and I think it's a good test, but not necessarily for all patients. And so the next test we actually did do in this patient, we did not do this lymphocytography in this patient. We actually went on to do an MR lymphangiogram where we injected gadolinium into the inguinal lymph nodes bilaterally that were cannulated outside the MR scanner. We then bring the patient into the scanner and gently inject by hand our gadolinium up into the lymph nodes. And there you can actually see it track through the pelvis, but we don't really see it get very far. So we actually can see the lymphatic channels actually opacified, but we don't actually see a full thoracic duct. We never really got this far. Some of that could just be some back pressure from this effusion that was still collecting. So we didn't really know for sure if the thoracic duct was intact, because normally we would see a cisterna chyli, and then we would see the thoracic duct, and then we would see the lymphatic thoracic duct actually insert at the internal jugular vein and subclavian vein. We don't really see that in this patient. So, we were at this point starting our discussion with Dr. Itkin, Dr. Rabinowitz, and we actually did move on to do a lipidal lymphangiogram. And so first we drained every compartment of every fluid collection we could find. So this actually was draining off additional pleural fluid here, just to decrease as much pressure on that thoracic duct. We then cannulated the inguinal lymph nodes again and injected Lipidol. Lipidol is very viscous, it's kind of thick, so we may not opacify all of the small lymphatic channels that you might see with a water-soluble contrast like gadolinium, but we actually can opacify some of these channels. And given the fact that we're using, we're not in an MR scanner, we can cannulate nodes higher up if we need to, and we can use a little bit more pressure if we need to. And so with this, we were actually able to opacify more of these pelvic channels, but then also get up here into the thoracic duct. So here are the pelvic channels here, and then actually you can see this probably is the beginning of a cisterna chyli over here. We don't see the full thoracic duct in continuity, but we do see a tortuous duct up here, and then we do see a little lymphatic reflux up by the neck. So we were able to at least do that and hopefully get our patient stable enough then to go out to the moors.
So it's probably a good time then to, in real time, it goes out to Dr. Rabinowitz and Dr. Itkins, and clearly, one of the first things on the plate is how to troubleshoot the lymphangiogram images to actually find, where the shunting is and where the leaks are. What can you kind of, as we go through your slides, tell the audience about how you troubleshoot to get the image and to get what you need out of these?
Yeah, so the first thing that you said was exactly right. You have to, it's such a low pressure system that you have to decompress all the compartments that may be putting any pressure on the duct itself. So draining as much chest, pleural effusion as you can, draining any ascites that you find as well. The next step was also, we would always do an MR lymphangiogram, as we did on this patient. And you can see here, so the image all the way on the right of the screen is the pre-contrast image, where the arrow is. That's our lymphangiogram pre-contrast image, and you can see the mass in the mediastinum and the chest wall mass. And then the image on the left is our post-contrast. So after we do a lymphangiogram, we usually get a delayed post-contrast image, and you can see actually the contrast leaking into the subcutaneous tissues there and outlining the subclavian vein where it should be entering. So even without, we had functional images of the thoracic duct, but even without those, you can tell that this is obstructed and at that point and is leaking into those tissues there. And then this is a video of our actual MR lymphangiogram. Hopefully it'll play. So again, you start to see, the contrast in the retroperitoneal lymphatic system, and then as it progresses slowly, it goes up to the thoracic duct, and then again just doesn't go into the into the venous system, but is accumulating up there in that neck, in that area of one of the masses that we were seeing. All right, so at this point, sorry, I think these are out of order. Is there another more?
Is this one good, or
is there? Yeah, that might be. Is there another one at the end? Did I show you? I didn't. Okay. So our her lymphangiogram. Yeah, this one should be good. Her lymphangiogram demonstrated, we cannulated her thoracic duct, and then we did a lymphangiogram. This is actually the intraoperative images. Maybe I didn't send the lymphangiogram.
Yeah, I apologize if we have them out of order.
No, that's okay. All right, can I share my screen to show her lymphangiogram? Because it's a pretty nice,
if you want to give it a shot, it would be a good time for that.
Yeah. I can actually show you our CT. So here, how do I share my screen?
What you want to do is go to the top of the main slide screen, for the video thing here, and then on the right-hand side, you'll see 3 dots. Scroll down to the share, and then share my screen, and then pick the thing on your screen you want to share. You see where that is?
No. I see like a box. Hold on. Oh, I found it. Huh. Look at me. Share. It's just, I think it thinks I'm already sharing. Can you see any of my screens?
No, you have to pick the screen you want
to share. Oh, here it
is.
Share my screen. I found it. I'm
go.
sorry. Let's see if this is the right screen.
There we go.
So here is her. For some reason it made everything go down. Let me see if I can find you guys again. Like I can't see you guys, but can you see me?
Can
you see my screen?
We can see
yes,
you
we
if you
can.
want to show it.
Yep.
Are you seeing like a lymphangiogram?
Yep.
Okay.
Yes, we are.
So right here we've cannulated the thoracic duct percutaneously. This is a microcatheter we have in her thoracic duct, in her cisterna chyli basically, and then you see the contrast heading up, going up towards the neck, and then you start to see this abnormal branch that's going sort of into nowhere. You see this branch that goes down directly into where the thoracic duct should drain into the subclavian vein and is very narrowed and doesn't drain at all. And then you see this upper branch, which I've conveniently cut out of the screen, that is leaking up there. And we actually tried to, we tried to select each of these branches and get better images. And then I can show you. So at this point, this is what she looked like. And this is just this is from her cone beam CT lymphangiogram as well. So this is just on the table. It just gives you a little bit of a better idea and the better anatomy for our surgeons. You can see this was that narrowed thing that goes back to the main thoracic duct. And we get this in 3D images so that the surgeons can localize where, we can help the surgeons localize where the duct is and where they need to access, because the neck can get confusing.
I appreciate that. I have to think that as you're doing these, you're also thinking, what is the appropriate intervention, and of the options of interventions, I wonder if, we could start with you, because if you could start to talk about what are the different approaches you would do to plug the leak.
Right. So this leak was partially plugged by the Lopidol that that Aparna gave, and then also partially embolized by the Lopidol that we gave during our lymphangiogram. And so she was in a much more stable place at this point, and we had time to discuss this. So we did the lymphangiogram, and the real two options are to try to do an angioplasty through the duct to venous anastomosis where it's narrowed, if you can get through it, or to just do a re-anastomosis of the thoracic duct to a different vein. And that's a decision we made to go towards. And then we referred her to our microsurgeons to do a reconstruction.
Max, I wonder if you want to add to that as far as, you look at this lesions and lesions like it, and what is in your tool belt as ways to go after this? Dr. Binowitz just described, the likely path for this child, but what are your options on the table? We got you mute. We got you muted, Max. We're still muted.
Yeah, sorry. The thing's evolving. So originally we always did embolization, and over years we started to do this communication, started building communication between thoracic duct and veins, right? And first, because the surgery developed and people started to do more lymphovenous surgery, number one. And what surprisingly how patent these connections are. It's absolutely, I was absolutely sure that when we published this paper and my microsurgeon did 1 millimeter connection between thoracic duct and vein, it will be clogged in a day, and it's not. We actually have few follow-up studies where we showed that even weeks after that, and in adults I have a even year and a half, this anastomosis is absolutely perfectly patent. There is something about lymph that prevents this restenosis, and that's kind of encourage us to start thinking more about reconnecting than blocking, because on the same time we started to see more and more patients coming to us with problem of a thoracic duct drainage, and the moment we reestablish this connection, the problem disappears. The problem could be Chylous ascites, protein-losing enteropathy, or recently we started to see more and more patients with severe abdominal pain because of the occlusion thoracic duct. So first thing right now, we're thinking, how can we reconnect lymphatic system back to vein and disconnect it from malformation or from leakage? If we can do that, by all means, we'll do it first. We'll do every effort to do that. Even though we know that embolization thoracic duct is safe, but still we will try to do that because it's definitely a better approach.
I want to just add that we have had some patients that have come in for a lymphangiogram years after having a thoracic duct ligation. And what we actually did see then was that the lymphatics actually just reroute themselves. And this patient who initially had a thoracic duct ligation for refractory pleural effusions was now having pleural effusions, but there was no thoracic duct to actually treat. It was actually from other sources of leakage. So it could have been from an intercostal lymphatic, it could have been from somewhere else that we actually couldn't reach anymore. So to speak towards the direction of surgery and reanastomosing and preserving those structures, you know, I see completely where you're coming from with that.
You know, and you know, I'm the oddball non-interventionalist or surgeon, you know, at the table here, but I've always, you know, shared this fear of some of the, you know, the classic interventions, thoracic duct ligations and pleurodesis, you know, just to mention it, chemical or surgical pleurodesis. These are, you know, these are interventions that have always been the, you know, break the glass at times of, you know, life-threatening scenarios, but also have been in algorithms of fairly standard of practice. And I always carry the worry, especially in pediatrics, you know, so we're, you know, young children, that we're making dramatic scarring or dramatic changes for the rest of their lives, you know, that impact it. So, you know, I think it's a good time point because I have a few slides here for Dr. Cato to kind of say, you know, when you're presented with the situation and you're collaborating with the interventionalist and trying to decide, you know, is this interventional, is this surgical, or is it an adjuvant? You know, do you guys work together? You know, as happened in this case. What goes through your decision making, and then we'll get into your first slide of your technique.
Okay, thank you. So my basic concept is just as Dr. Taizo talked about, to naturalize the lymphatic disorders. So the lymphatic flow is supposed to be naturalized. So if the situation is lymphatic congestion, I would try to connect and make the bypass and shunting to let it flow. So lymphatic venous anastomosis is one of the options to lymphatic flow naturalize. This is a peripheral lymphatic venous anastomosis I showed here. Is only 1 to 2 centimeter skin incision is required, and under the skin, in the very peripheral area, the small lymphatic channel and the venule is anastomosis under the microscope. So could you go to the next slide? Okay, so this is one example of the video I provided. How actually lymphatic channel and the vein is anastomosed. In a very short movie, so it's very not detailed, but in the upper part there is a peripheral vein, and the lower part is a lymphatic vessel. This is actually done for the 1-year-old baby who had the Chylous rux, and she had the congenital lymphatic channels down to the thigh level. So this is this anastomosis performed on the thigh. And small nylon thread is inserted in the channel to keep the caliber open, and this is the end of the anastomosis. So can you go to the next one? Thank you. Okay, thank you. So in the lymphatic venous anastomosis, making the shunt can do any part of the body if the hands can reach to there. So on the left up part, I showed the peripheral LVA. This is a different patient, but in 2-year-old boy who had the chiral abdomen, and the performance was done, the anastomosis was done, and the thigh. And the lower part is thoracic duct and jugular vein anastomosis, which is just exactly the Max talked about. And on the right upper part, this is the way of the anastomosing directly from the lymphatic malformations to the venous system. So some various way we can make the shunt. Thank you. This is.
You know, that's really elegant. You know, it may be, you may have chosen the most simple video for yourself, but I think it brings a smile to everyone's face just to see how elegant it can be. You know, I want to, because we have a couple minutes, you know, get back to the point that, you know, Dr. Rabinowitz added to the comments, you know, and she says that, you know, especially in systemic lymphangiomatosis patients, it's important to consider preserving the thoracic duct. So here we are, you know, all of us out there, you know, within, you know, this webinar, you're stuck with really symptomatic, you know, kid in your ICU. You know, they're struggling to keep the fluid balance, the electrolytes, the albumin, the IVIG, things that we've talked about. And, you know, it seems to be refractory. It seems to be refractory to the measures that we're taking. And, you know, there's this instinct to do something dramatic. And the two of them that kind of scared me the most that I mentioned are ligation of the thoracic duct early on, and pleurodesis, you know, chemical or surgical. And although they may get the job done in the acute setting, you know, I'm curious, you know, how do you counsel the, you know, you have an ICU calling you saying, we're not getting better, we're refractory, you know, I'm gonna do something, we got to do something. How do you temper the, you know, the balance between this, you know, the kind of elegance of a targeted therapy, I mean, targeted intervention or surgical therapy versus something that's, you know, a little more blunt but gets the job done? And maybe we'll start with Dr. Rabinowitz since you put the comment up there. We have,
yeah,
you muted.
Yeah, you hear me now? I think that I think the stability of the patient is the key. So this patient initially was leaking so much that she was getting into DIC, and she was really having trouble keeping her intravascular volume, and she was really getting into serious trouble. And just even oxygenating. And so at that point, everybody gets a little bit panicked, and it's understandable. And if you can't get that under control in a time, you know, these microsurgeries take a while to organize, and they're long procedures, longish, and usually not like in an emergency situation. So if you have to just consider that, you know, if you can't get the patient stabilized, then you may have to do something, you know, sort of more dramatic, like embolize the thoracic duct. I think pleurodesis in these patients, if you haven't addressed the problem, is going to be difficult, because it's like you're trying to attach the pleura to the pleura, but there's like a constant leak of fluid going in there. So I think that's a difficult, like a lower chance of success anyway. So I probably wouldn't start with that.
Dr. Inkins, anything to add as far as, you know, the decision making, you know, in a sick refractory patient, you know, that you have people pressuring you that they'd like to do something more dramatic to the thoracic duct or pleurodesis, how do you leverage and I think acuity is the point, but anything to add as far as how you leverage that decision making?
Yeah, it's tough question because I mean I will do everything right now to preserve a flow. So there is something about some patient that their flow is significantly, lymphatic flow is significantly elevated. Definitely all lunar patients, or down patients, but also lymphangiomatosis. So 5 liters a day for the girl that weight maybe 20 kilos, that's kind of lot. It just indicates how much lymph is produced. So you kind of assume that that this needs to be redirected back to the vein. So I will just say I will try very, very selective embolization with preservation on the table, with preservation of the thoracic duct. And the way we do that, we actually put 2 catheters inside thoracic duct. And while we selectively embolize in one branch, we infuse the D5 through the second catheter, pressurizing thoracic duct, making sure that everything we inject go peripheral, not refluxing back in thoracic duct. That's what one of the options to do the selective embolization while preserving thoracic duct for the future interventions.
No, that was great. I appreciate that. I wanted to take a couple points. I'm going to go back to one thing that I think maybe you guys will think is cool in my side of the coin. Here. So I don't know if I've actually shared this with you guys, but we I'm a hematologist. That's why I'm the oddball of the table here in the discussion. But you can't help yourself but follow that this is for our patient. Following some of the coag parameters throughout her stay. So what we have, going down is when normal values when she came in admission, a week in when she's, starting to decompensate with high flow, and the 2-week mark, which actually had a number of interventions by Dr. Anam, including the Lymphangiogram that tended to plug a few of the leaks. And so you can see that, just as a general trend, our platelets were going down, our fibrinogen was going down, our dimer was going up as far as the products. But here are some interesting ones. Because you always think, what is the content of lymphatics as far as factors? You can't clot in lymphatics, right? You don't have enough clotting factors to make a clot in lymphatics, but so what's in there? Well, the von Willebrand's level in the peripheral blood was going down. The factor 7, the factor 8 we were watching, maybe those aren't so clinically significant factor 8 levels, but it's low, and so there is a leak of these proteins. There's a leak of these into the lymphatic fluids that is a progressive coagulopathy over time. Again, for the sake of time, we were doing a few TEGs, thromboelastograms, which is kind of a global assay of the ability to form a clot and break it down. And we were seeing the progression of a very unique coagulopathy that we could improve upon with these assays. But, the feeling was we were just kind of putting our fingers in the dam with the Lymphangiogram lymphangiograms. We weren't creating sustainable responses. It really took the interventions, the surgical component, and then the anastomosis component to get her to a place with you guys that this could be sustainable. I should add a column to this because since you returned her to us, I've repeated a number of these and they've normalized, and that's really cool in a nerdy hematologist world. The other point I wanted to mention, kind of finishing up, is I can't help but mention the medical management to a component. In a day and age where we're getting better at targeted pharmacotherapy, why aren't we throwing some of the heavy hitters? Ask your doctor if alpelisib, trametinib, are they right for you? Well, I think we're at a very comfortable place, as you guys probably are in the field, where if you don't have a gene and it's a complex lymphatic malformation of some kind, we're probably very comfortable with sirolimus and its dosing, its safety. It is probably the agent that if you haven't had a gene target yet, you could still say we have enough safety experience to use. I put bisphosphonates there, which is more of a a thought of bone, helping bony disease in the GLA Gorham-Stout population. I don't think we can get into it too much, but I think it would be enticing to your multidisciplinary hematologist oncologist to say, is this going to be a pathway that a targeted PIK3CA agent like Pellicip would work on? Is this going to be something that trametinib could work on as a MEK inhibitor? You guys were able to obtain tissue during one of the procedures that was sent to a few different centers now, including Seattle Children's and our own molecular core. And unfortunately, we have not been able to identify a low-hanging fruit variant to say that a more targeted agent, like in the long run, like trametinib or Pellicip, is going to be the winner. We do still have the patient on sirolimus as an adjuvant. How much we give the sirolimus credit over what is the grossly obvious collaboration between the interventional and surgical component, but I think that whether it's a comforting thing at the moment, or we're wanting to see if we can have slow changes or slow preventive changes over time, we still have the patient on sirolimus now. We're at the final minute, and so I think what I'll do is just ask you guys, kind of one at a time, your kind of closing thoughts on the case, and any tidbits of advice on similar patients that you would have for the audience. So maybe, Dr. Nam, I don't know if you want to start with any thoughts you have reflecting on this case and the outcome.
Well, I have to say, I'm really thankful for the collaboration and really thankful that we were actually able to get this patient to something that was a more definitive and better approach for treatment in the long term, and that her thoracic duct was preserved, and that hopefully she will continue to do well. So I think that's, for me, the take home from this is, if there are interventions to be done, certainly imaging, all of this plays a role, but if there's a way to preserve the duct and give this patient the best long-term outcome, I think that should be pursued.
Dr. Rubinowitz?
I agree with everything that Dr. Anam said. I do think that we should continue sirolimus in this patient because she had all of those masses, and I can't 100% say that some of those are not just lymphangiectasia, lymphangiomatosis, rather than like the leakage itself. So maybe the spleen, maybe the bones. So I think that preventative or preemptive sirolimus is a good idea for her as well. And from what I've seen, her actual superficial vascular malformation is much improved. When her mom sends me pictures, I don't know if you've seen her in person, but it looks much better. So I wouldn't say that was all the thoracic duct draining. And wonder if
Dr. Akins.
So number one, I think we need to use more and more MR lymphangiography for these patients when they've been diagnosed. So in her case, it's clearly the growth of the thoracic of these masses was because of the thoracic duct was empty and pressurized with masses and entice them to grow bigger and bigger. Number one. Number two, access to good, unique expertise of lymphovenous anastomosis is crucial if you would like to build a successful program. We're fortunate to have amazing vascular microsurgeons and Steve Kovach and EJ, and they both amazing surgeons, dedicated, focused, and would like to do new stuff. So that's we are big winners because of that.
And Dr. Cato.
Okay. Well, was a very exciting meeting, and I totally agree with everything you said. And just the thing that these lymphatic disorders examination and the treatment is upcoming new things a lot. So we have to keep updating, and multidisciplinary approach is very necessary. So good communication and good talk with the experts would be a good future, I think.
Yeah, and I thank you so much for joining us. I hope that, you know, there's a day and time soon that we can get you over here. You know, we'd obviously love to have you as a guest in person, you know, at some point in time when the world allows it, you know. But appreciate that there are platforms that allow us to connect us from the East Coast to Central United States to the middle of Japan to Argentina, Peru, Kentucky, and Spain. Look at that. I want to let the audience know that we love the feedback. We try to improve the program and are studying how well we're doing as far as an educational platform. And so if you can take a quick QR code with your phone on the screen, you know, and provide any feedback. We hope to do this quarterly and you know, thank everyone for joining us. Thank you to the Hendron Projects again as our host, and we hope to be back soon in the next couple months with another case. Thank you again to all our guests. It was great to have you. Really fun to have you guys. Thanks for taking the time.
Thank you.
Thank you. Thank you very much.